بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على نبينا محمد وقائدنا ومعلمنا عليه أفضل الصلاة والتسليم. الزملاء الأعزاء، الضيوف الكرام، يسعدني أن أرحب بكم جميعا في المؤتمر السنوي 23 للجمعية السعودية لطب الأطفال حديثي الولادة. إن انعقاد هذا المؤتمر يمثل التزامنا الجماعي بتطوير رعاية حديثي الولادة وتعزيز جودة الخدمات الطبية المقدمة لأصغر وأعز مرضانا، تحت شعار الخطوة الأولى نحو حياة صحية طول العمر. يجتمع نخبة من الخبراء والمتخصصين والباحثين والممرضين من داخل المملكة وخارجها لتبادل الخبرات وعرض أحدث المستجدات العلمية والتقنيات في مجال طب الأطفال حديثي الولادة. خلال الأيام الثلاثة القادمة سيتناول المؤتمر موضوعات محورية تشمل الذكاء الاصطناعي في الرعاية الحديثة، استراتيجيات التنفس المتقدمة، طب الأم والجنين، والتغذية وصحة الأمعاء. ونحن فخورون بمشاركة نخبة من الأساتذة والخبراء العالميين والمحليين الذين سيثرون جلسات المؤتمر بعلمهم وتجاربهم القيمة. كما تواصل الجمعية السعودية لطب الأطفال حديثي الولادة التزامها الراسخ بدعم التعليم المستمر وتحسين الجودة وتعزيز الممارسة المبنية على الدليل العلمي في جميع أنحاء المملكة وخارجها. أتوجه بخالص الشكر والتقدير لجميع أعضاء اللجنة المنظمة واللجنة العلمية وأعضاء مجلس الإدارة في الجمعية، المدير التنفيذي، السكرتارية، ولجميع الرعاة والمتطوعين على جهودهم المخلصة في إنجاح هذا المؤتمر. نسأل الله أن يكون هذا اللقاء منبراً للعلم والتعاون وفرصة لتعزيز الشراكات التي تسهم في رفع مستوى رعاية حديثي الولادة في منطقتنا وفي العالم. أهلا وسهلا بكم في الرياض، وأهلا بكم في مؤتمر الجمعية 2025، وإلى رحلة علمية تجمعنا على هدف واحد: مستقبل أفضل لحديث الولادة. وعلى بركة الله تبدأ فعاليات هذه المؤتمر. اللهم انفعنا بما علمتنا وعلمنا ما ينفعنا، والسلام عليكم ورحمة الله وبركاته.
Assalamu alaikum, sabah al-khair. It's a pleasure to be in the 23rd SNS this year, and it's a pleasure also to moderate this session with Dr. Yahya al-Malki. It's going to be about quality improvement and patient safety in the NICU, which is the core of neonatal care, where small changes make huge differences in baby's life. We're going to start with the first session, which is going to be presented by Dr. Adnan Al-Hadid. Dr. Adnan is a consultant neonatologist at King Khalid University Hospital in Riyadh with 15 years of experience in advanced neonatal care. He's a recognized leader in neonatal resuscitation, quality improvement, which he's going to talk to us about today, and research with multiple international publications. Dr. Al-Hadid, he's also an active educator and conference speaker dedicated to advancing outcomes through innovation and collaboration. He's going to talk to us about building a culture of quality and patient safety in ICU. تفضل دكتور عدنان.
شكرا جزيلا دكتور. السلام عليكم، حياكم الله جميعا. I agree with you that not all the people like quality, maybe most of us. Why we don't like quality? There's a lot of reasons. We'll try to inspect in this talk. First of all, the content or the outlines of my lecture I'm not going to talk about it in details, and it's not in order, and it's not the same and exact title. You'll not find it there. I think it's very famous. You know him? علي عزت بيغوفيتش رحمه الله. في له مقولة جدا شهيرة: لا تقتلوا البعوض، جففوا المستنقعات. من الأشياء الصراحة يعني it's fit for the quality بشكل رهيب جدا. Anybody can interpret this talk or this sentence: لا تقتلوا البعوض، جففوا المستنقعات. It's reflecting what in quality? Root cause analysis. So treat the cause, not the result. I think we are facing this problem from time to time. There is a problem, there is a mistake from nurses, from doctors, from anybody in the ICU. There's two nurses, they did the same mistake. One of them, she get the wrong medication and she gave it to the baby and the baby died. The other nurse, she get the same medication, it's also wrong. But she realized that this is the wrong medication and she did not give it to the patient. And luckily the patient survived. This is what we call it near miss. I think we are facing this one in all of our hospitals. But I need you to scan the barcode and to answer. In this case, what you will do in your hospital for these nurses. Hopefully it will work. Okay, so just scan the barcode, and in your hospital, a nurse, she get a wrong medication, she give it to the baby, and the baby died. How many of you will end her contract? How many of you will give warning letter? Or maybe something else? Can we scan the barcode, please, and answer? So right now we have 13 working on that. I'm not saying what you will do yourself in your hospital, in real life. I'm quite sure maybe 99 of us will end her contract, no doubt. And this one will reflect honestly the real quality, what should be, and the way how we are practicing quality. There's a big dissociation between them. 26, I think we need a little bit more. I'll give you 10 seconds only. Then we'll give the answer. Not the answer, the things you answer it. So, honestly, I anticipate that 90% of you will end her contract. End of contract, only 7%. Very strange. I believe that most of us will end the contract and punishment. So, honestly, without looking, before we are saying don't Google it, now we are saying don't look in ChatGPT. Do you know what is LASA? You can answer also, you can vote. If you know LASA and what the things you will do it in case if you have LASA, what you will do. Because this one will reflect the way how you are thinking in this case. Are you going to treat the nurse in the right way or no? So still 0. Again, we give 10, 15 seconds. I think it's well known, isn't it? Nobody. ما وصل؟ غريب ممكن ما طلع الأرقام هناك. Okay. 0. Okay. So 50-50, it's not bad. I think most of us going through Sibahi, Canadian, Australian, DCI, or whatsoever, during that, the quality department will come to tell us, this is LASA. If they ask you, you will how to answer, but they will not teach you how to think about it. So, first of all, what is equality? What is safety? The way how to give that definition, I think I don't agree with a lot of people saying that the quality is to do the right things, but at the end, you'll not understand anything about equality. So there's 6 domains of equality. We are going to focus on safety because really it's the most important domain of equality. This presentation, I gave it the last conference. It seems to be the same. And this is my definition of equality. You can see, this is the real quality. This is how we are practicing quality. But there is no sound. ما في صوت. في صوت or أنا بكون روح كل السلايد. Okay, it's useless. ما في صوت. طيب, in brief, I will tell you. This is the real quality. إحدى السيمفونيات بيتهوفن. There's coordination, there's leadership, there is harmony, they are following standards, they are doing real quality. While indeed, in the next one, there's no harmony, there's more than one leader, people that don't know what to do, there's clear distraction from here and there, and this is the way how we are practicing quality, even we know everything about quality. So, but without sound, I think it's useless. طيب, again, without sound, I think you destroy half of my lecture. المشكلة اعتمدت على الفيديوهات كتير, and what he will say, first, do no harm. This is the safety. السلامة أولاً. And I think it's well known. Without sound, I think مشكلة. The best translation I found it for, to err is a human, كل ابن آدم خطاء. This one, 1999, Institute of Medicine, they said that we are a human being, and we are doing mistake. And even it looks very simple, but it's changed the whole story of quality. Because the way how we think, the way how to treat the quality is totally different. So to err is a human, Institute of Medicine, 1999, they said that the quality is freedom of accidental injury. This is our perception as a physician, as medical staff. We believe that if there's no harm to the baby, that this is a quality. But not all the people will look at the same, from the same angle. So there is difference between how we are looking at the safety from our side and how the family is looking at the safety. So for us, we are focusing of no medication error, no problem, no any accident happened to the baby. Well, the family will focus about something totally different. How to solve this problem, how to make it together. I think we'll have lecture tomorrow, which will be presented about family-centered care. So we can join both together in one view. This is what we call it, family-centered care, and I think it's one of the core important standard of Canadian accreditation nowadays. To err as a human, 1999, then Institute of Medicine, 2001, they said it's okay, let's try to fix this problem. We have a lot of problems in quality. How to cross this, what we call it بالعربي الهوة, في فجوة, في هوة, between what we practice and what the real quality. So the issue again, the crossing the chasm, and they put a lot of things, how to think, how to treat, how to deal. Quality, like anything new, even if we are practiced more than 20 years, but it looks like anything new. Some people will believe on it, you can argue with some of the people that you can convince them to start quality, but you will shocked here. You will stop here. Honestly, I'm practicing quality more than 5 years now in our hospital, but we're still stuck there. It's not easy to convince the people to practice real quality. There's a lot of causes. Maybe it's need more than one lecture, but the message, if not all the people working with you with the quality, this is a real situation. This is the life. Not all people believe in quality. To be safe, you should have what we call it quality culture. What is a quality culture? How to build it? And which type of culture you have in your hospital. It's different from hospital to hospital. Before that, we should know what is the system. I think all of you know Edward Deming. He's the father of quality. He said that the system is the process and policies, management decisions, training, education, tools and resources, and organizational chart or culture. When Deming talk about the system, he's referring to the entire environment in which people is work, and that's what is included there. This is the system. So how to build the system? We have two problems. First of all the people nowadays, they said, blame the system, don't blame the people. That is it right? That's we should blame the system. That's 85% of our problem is coming from the system rather than from the personal. Some people saying it's 94%, and this Edward Deming said it's 94% of our problem is coming from the system. But indeed, you can read it in different way. That if you fix the system, you can fix up to 85 or 94% of your problem in your institute. So you should focus on the system. Focusing in the people, this is what we call blaming culture. Focusing on the system to fix it, this is what we call it non-blaming culture. So again, he's saying if you fix, again, there's no video for that. I think should be fixed before 1 day or 2 days in the conference. It's not accepted, the video is not working in them. You spend a lot of time for that, then you'll, مشكلة. Okay, what he's saying that if you fix the system, you will be able to solve 85% of your problems. That's why if you have any problem, any mistake, any medication error, try to fix the system. Look what is the cause in the system rather than to keep blaming the people, and the problem will keep happening again and again. طيب, we have two ends, blaming, non-blaming. Can we have something in between? Balance between blame or not to blame the people at all? Any idea what we call that culture? Just culture, البيئة العادلة. Okay, it's coming. Or okay.
85% of the reasons for failure are deficiencies in the system rather than the employee.
Okay, 85%, and he said 94% even. So there's two ways to think if you have problem. First of all, either to blame the people for any mistake that the nurse caused the problem, or you should come and discuss how to fix the problem because you have a lot of barriers, and this is what we call it Swiss cheese model, that you have a lot of barriers before the problem will happen. You should look what you have, problem in the training, problem in education, a lot of things, policy, procedure, administration, or whatsoever. This is the way how to think rather than to come and blame the people. And honestly, I find it extremely nice. He will tell you, we have 30 or 40 nurses covering 40 bed in ICU, and he's wondering why the mistakes and problems happening again and again. You are not looking like a Swiss cheese model. You have a big hole. That's the problems can happen daily. So blame yourself, not the nurses. Iceberg, it's very important. If you discover one problem in your NICU, one mistake, that's okay, we have one incident. That's a problem happened there, medication error. Multiply by 10. And you see that the latent failure, it consists of 90% of the iceberg. So you have 10 times the problem still hidden, and you are not discovering it. So don't say I have one problem. Honestly, you have 10, but you discover one of them only. So blaming, it can destroy the whole work. Non-blaming, it will affect the system. So try to balance in between. البيئة العادلة, just culture. So blaming, non-blaming again, just culture. I'm focusing on just culture because we have a very big policy, but still right now we are practicing blaming culture. How to build up just culture? Educate the staff, train them, and follow the standard. Sibahi coming, we are doing our job, then we forget everything. This is our problem, honestly. Type. There's what we called 10 patient safety for hospitals. I'm going to talk about 10 only because it's going to take time too much. Did you hear about FEMIA? Are you practicing that in your hospital? Anticipating the problem before it will happen. You are practicing yearly risk registry, which I think nobody likes it at all. But you can discover a lot of problems before it's happening. This is a proactive way how to discover the problems. We are blaming sometimes the resident or the doctors. They have before 30 hours of duty. But it's evidence-based, and it's issued by Institute of Medicine again. There's correlation between the shift hours and the problems. So if you have a doctor's working for 30 hours sometimes, shift, so you should blame yourself, not the doctor, if you have any problem or any mistake. Focusing about patient safety organization, PSO. Maybe there's different names here and there, but you can say it's like المركز السعودي للسلامة Safety Center. If you are reporting for them, you can get a lot of data, you can analyze, you can learn from your mistakes. Or you can report in your hospitals. So collect the report, aggregate data, analyze it, and share learning with the others. And you can solve a lot of problems. We know that the medication errors is consisting at least 28 or 30%. Diagnostic errors and health care associated infection. If you don't have data here, all numbers would not be clear for you. You don't know how to treat what you have problems here and there. So without data, you cannot work in research, you cannot work in quality. Estimated, it's long time, this numbers, that you can save the life of more than 90,000 persons by following very simple safeties. This is the numbers. Medication error always coming at the top. Following some quality improvement project, focusing on quality, it can save a lot of lives. So if you focus or you start here, you can see that the numbers going over 3 to 4 years sharply. What the benefit of reporting, learning from your mistakes, learning from your errors, that you can build what we call proactive risk reduction, enhanced safety culture, access to expertise. They can help you data-driven decisions, not guessing that we don't have problem. You have a lot of problems that you are not reporting. This is a problem. Performance benchmark, national, or from different hospitals or whatsoever, reduce trigger problems. And honestly, it can help you a lot. So don't waste a good mistake to learn from it. I think all of you know what it's International Patient Safety Goal. I'll talk about only one of them. This is what we say about communication. Communication, I think you're not surprised, that's 80% of our problem in communication, and mistake is coming during the handover in the NICU. That's why we are focusing too much on it. There's a program, what we call Team Steps. I don't know if anyone heard about it. I put it in the drive. I will send it to you at the end. So, this is all the presentation for me. ما أدري هي بالعربي الرجال من الزهرة والنساء من كوكب تاني، يعني ما يفهموا على بعض، ما في communication between them. So I chose the same title, that's doctors from Mars and women or nurses from different place. So there's no good communication between the nurses and the doctors. And this can cause a lot of problems. How to solve it? SPAR or STIPS. STIPS, I think, need more than one lecture, but I will talk about the outlines of STIPS, how to improve that things. Quality improvement projects can help you a lot to improve your safety. I'm not going to talk about CLAPSI because Prof. Sefi will talk about it, but I will remind you if you have a lot of projects to work or to do at the same time, you should follow what we call 2080. حدا يعرف إيش الرeflection بالعربي؟ في مبدأ إسلامي, it can reflect Pareto. فقه الأولويات. فقه الأولويات. We focus on 20%, which we call it vital few, which can, 5 minutes, يعني, which can solve or fix 80% of the problems. So this is Pareto, what we call it فقه الأولويات. Okay. This is another talk I'll present tomorrow, but it's in Syria, online. Golden Hour. Golden Hour, I think, is one of very known project in equality, focusing on the first 60 minutes of the PABG life and what the things you will do it. Quality improvement project need two things. First of all, working in a bundle and following the best evidence. You have it. Bundle. بيت الشعر تأبى الرماح وإذا اجتمعنا تكسرا وإذا افترقنا تكسرت أحدا. This is the principle of putting all the intervention together. Golden hours can decrease severe IVH, PPD, mortality, admission, hypothermia. It can help you a lot. And this is a golden hour, decreased by 35% of severe IVH. And it's evidence-based, published in Pediatric. There's a lot of quality tools you can use it. We are following Focus PDSA, but Canadian. By the way, we translate the material into Arabic, and we start to teach it in Syria recently. This is one of our projects, fixing the admission hypothermia in our hospital. Luckily, after working for 6 months, we were able to decrease it by 20% only, 6 months. We trained more than 200 nurses, doctors, people, simulation, and it's end by decreased 20% only. So you need a lot of efforts. I think it's reported by Prof. Faleh before, we have 70% of admission hypothermia. We decrease it to less than 30% now after our project. This was our project. Again, المشكلة البوينتر مو دائما. Okay, governance and leadership, I think most of the time is not going to help you, but they should. Do you agree that there's no quality without authority? لا رأي لمن لا يطاع. مقولة علي بن أبي طالب كرم الله وجهه. لا رأي لمن لا يطاع. That doesn't mean you should force the people or push them to do quality. At least you should have organized things from the leaders they can follow, not to pushing them. Nothing can be by force in equality. Team steps, I said I will mention the outlines only. That's focusing on the team training and communication, simulation-based training, checklist, care bundle, collaboration of QI networks. And this is the principles of it, because it's really huge. I'm not going to talk about it in details. It's include team structure, communication, leadership, situation monitoring, and support. There's steps: assessment, then phase 2 planning, training, and implementation, every single step there. and then how to sustain it. Honestly, don't trust AI in everything. I did it last night before I sleep, but I discovered that it's catastrophic, really, the way how View 3.1 even, he did it as a video.
The process begins
but
with
it's full of
Phase I
mistake.
assessment,
So
leading
don't
into
trust it
Phase
always.
2, planning, training, and implementation.
Most of the arrows is wrong. Sorry for that. So there's barriers, there's tool strategy, there's outcome, how to do it. There's a file, I think it's close to 50 page. I put it in the drive, I will send it to you. Family-centered care. We know that's what is the principles, dignity and respect, information sharing, partnership and participation, collaboration, but involving the family and to be family-centered care, it can decrease mortality, can decrease stay in the hospital, can have a lot of benefits touching the safety. AI in NICU, I think Dr. Jabara will talk about that. So I'm not going to focus about it. Machine learning, how they are predicting sepsis, things, a lot of things you can monitor, a lot of things you can do with an AI nowadays. And you see, to pick up sepsis, it will be much earlier than depending on the routine things. But again, you should have data. Without data, it's useless. AI, research, quality, it's useless without data. Exactly. Good system. And at the end, I believe that the staff, following standardization, building good system, it will end by safety of the patient. And this is a core focus for you in your hospital, depending on the staff to build the quality and the patient safety. So it starts and ends by the staff themselves rather than the administration. So if you are interested to get a copy of my lecture, step, and I create a video of 7 minutes. It's summary of my lecture. Maybe في شغلة رابعة ما أذكر إيش هي. You can scan the barcode. Sorry. How to discuss this case, I create a PowerPoint of 20 slides, how to approach medication error, especially for this case, what is LASA, how to think about it, how to solve it. There's a PowerPoint presentation. You can find all in this barcode. خلصنا or ثواني. طيب, any volunteer can answer. When the nurse gives the wrong medication and the baby died, who is the victim? Is it the baby, is it the nurse, or both of them? Nurse. البيبي مات يعني معقول ما يكون victim هو. So it's both of them, and I hope that you will read about what we call it the second victim, to know how to deal with the people rather than to blame them. They are suffering a lot of pressure. We are starting to investigate things, a lot of things, while you need to support them rather than to blame them. Both of them, yes, you are right. So 50% of us suffering from what we call second victim in one time of our practice. This is take-home message. Honestly, how I did it, I gave my presentation to ChatGPT, and I asked him to create take-home message, and it honestly was perfect. Nano Banana, he created as diagram. We are coming every day to do our job, but we need to work on improving it. And quality is everything, responsibility, and thank you very much. يعطيكم العافية.
Thank you very much, Dr. Adnan. We will leave the question at the end. And again, thank you for insightful presentation. Dr. Adnan, he reminds us, as always, that the infection control and patient safety is not an optional. Both are in the heart of neonatal care. So we will move with no further delay to the second presentation. The second presentation will be with Dr. Saif Saif. Dr. Saif Saif, he is the chairman of the Neonatal Intensive Care Department at National Guard Health Affairs. Dr. Saif has a Saudi American Canadian board certified neonatologist with more than 20 years of experience in the field of neonatology. He is the former program director of the Neonatal Perinatal Fellowship Program at National Guard Hospital, Riyadh. And he is the course director of the Neonatal Pediatric Mechanical Ventilation and conference chair of New Brain, Saudi Arabia. Also, he is the co-director of the Saudi Neonatal Station Program. He has multiple quality and safety initiatives programs. He led the Zero Collapse campaign, achieving 820 days collapse-free in the NICU, and he directed the Zero Blindness campaign for more than 13 years with 0 cases of blindness. Lastly, he managed the neonatal bone fracture program, maintaining a 0 fracture rate among the high-risk infants from 2017 to 2022. Thank you, Dr. Saif, and welcome. The mic is yours.
Assalamu alaikum wa rahmatullah. Thank you, Dr. Yahya, for the nice introduction. I'm pleased to be here today. I'd like to thank the organizing committee and the scientific committee for inviting me to be a speaker in the 23rd Saudi Neonatology Society International Conference. It's a prestigious conference. I'm happy to be here. And also, I would like to thank the organizing committee to choose or to ask me to talk about CLABSI prevention experience in National Guard Hospital, Riyadh. Just an introduction for my talk that I like Dr. Adnan's talk, which give me a lot of easy talk about quality, because it's part of the quality to prevent CLABSI, because it's preventable. And at least 2/3 of the CLABSI is preventable. So I would like to emphasize that to treat CLABSI as an adverse event and need to be reported. But more importantly, to focus on what's the root cause for these CLABSI, rather than assigning blame. If we do this, looking at the root cause analysis, it will open door for improvement for our patient quality. So today I will dive with you and explore how we can achieve this. And we'll tell you our experience in fighting CLABSI. We are fighting CLABSI for the last more than 15 years now. Sometimes it's beat us, and sometimes, most of the time we beat CLABSI, alhamdulillah. At some point, many years ago, we think CLABSI cannot be prevented. When you see a sick patient, a lot of central lines, manipulation, crowdedness, shortage of staff, still you think it cannot be. Baby immunocompromised, but alhamdulillah, with the help of Allah Azza wa Jal and the team with you and maintaining the quality, we were able to overcome this issue. So my talk today will be summarized very quickly about what's the CLABSI, what's the magnitude of problem, chasing Zero CLABSI project, experience, challenges, our success, and if I have time, I will just give you some few slides about preventing CLABSI from the literature. So what's CLABSI? CLABSI, just as a definition, it's a laboratory confirmed primary bloodstream infection where an eligible BSI organism identified and eligible central line has been placed. What's the eligible bloodstream, which it's a laboratory confirmed bloodstream infection, is not secondary to another site. This is an important. An eligible central line is a central line that has been placed and for more than 2 consecutive calendar days, and such line to be eligible for CLABSI events, to remain eligible for CLABSI until the day after removal. So if you remove the line today and tomorrow you have a baby with blood culture positive, still we consider it CLABSI. So it's important. The definition changed from the CDC. It was 48 hours from removing the line. Now they make it 24 hours from removing the line. So healthcare or hospital-acquired infection is a major patient safety. 4 to 12% of patients admitted to ICU, they will have 1 or 2 infection during their hospitalization, and more than 600,000 hospital-acquired infection in patients in ICU in the United States. Each CLABSI events independently increase length of hospital stay from 7 to 23 days. This will lead to extra cost, estimated cost in the United States from $35 to $45 billion per year. More importantly, CLABSI causes 70% of all hospital-acquired infection in preterm infants And among surviving extreme low birth weight infants with hospital-acquired infection have 60% increase incidence of permanent neurodevelopmental impairment. And more than 70,000 patients with hospital-acquired infection died in ICUs, in hospital ICU in the United States. But encouragingly, that progress report from the CDC revealed 44% nationwide in the United States decrease in the CLABSI rate. How it's happened? The CLABSI is man-made. I think we either extraluminal, that mean during improper insertion of the technique, or poor maintenance of the insertion site. So the bacteria migrate, how can I go? Yeah, it's migrate through the catheter and embedded in the protein sheath. Or intraluminal, when you have a hub to inject a medication, without proper cleaning or omit cleaning of the hub, you may insert the infection to the baby. So this is an important major risk factor for infection. So what's the incidence of CLABSI in neonatal ICU? This is Pang et al. Published a recent article in 2025. It's a systematic review, a meta-analysis for more than 13 countries and more than 35 studies, collected 35 studies. And they found collectively the incidence of CLABSI from 2001 to 2022, 6.5 per 1,000 central line days. And the range of incidence from 2.3 to 18 per 1,000 central line days. And interestingly, that the CLABSI rate, it's nicely decreasing over the years, as high as 18 per 1,000 central lines and as low as 2.3. But for the last maybe 4 or 5 years, you see it's dramatic decrease in the CLABSI rate that's improved the outcome. In the United States, Sue published an article in JAMA 2020 looking at 132 ICU and look at the mean of CLABSI rate in the United States between 2013 and 2018. What she found that 1.5 per 1,000 central line days, the risk of CLABSI for babies less than or equal 1,500 grams. And 0.7, less than 1 per 1,000 central line days for those birth weight more than 1,500 grams. Interestingly, if you look at the graph here, from 2013 to 2017, there is no major change in the rate of CLABSI. It's static. That's after implementing the central line bundle or CLABSI bundle, the plateau for CLABSI rate maybe lead to consider it's just not expanding the surveillance of the infection of the CLABSI, not just looking at the CLABSI per se, but looking at all BSI, all blood culture positive in your department. This may improve the outcome of CLABSI because there is no change but looking only just the CLABSI rate. So, and in 2016, Rock et al., he published an article in his conclusion that the reduction of hospital-acquired infection has been associated with reduction in CLABSI. That makes us think that by extending the focus beyond the CLABSI bundle or a surveillance approach to surveillance all blood infection may lead to identification of opportunity to improve outcome. And this is what we have done in our center. It works very well. What about our kingdom? Habiba, Mamlakatana al-Habiba. Saudi Arabia, alhamdulillah, Ministry of Health, they start doing the surveillance for CLABSI in pediatric, in neonates, in adults. And Abdulaziz Shiddi et al. And his group, with the help of National Guard Hospital Riyadh, they did a collected surveillance for more than 100 MOH hospital between January 2022 to December 2022, and this data was entered in HISN, Health Electronic Surveillance Network program. And they have 15 maternity general hospital and more than 80 general hospital, and they have 63 neonatal units with the beds, total number of beds, 1,300 beds. What's the result? Our CLABSI rate in the Ministry of Health Hospital in the kingdom here is 3.7 per 1,000 central line days. They did a benchmark to compare ourselves to the international. Unfortunately, we are a little bit higher than NHSN, National Healthcare Safety network from the United States, which equivalent to Hisn. Yani Hisn is equivalent to NHSN in the United States. But the good thing is that we are less than the Gulf Corporation Center and International INICC, International Nosocomial Infection Control Center, which more than 5 per 1,000 central line days. So we are doing okay, but we need to improve better and better. So, and then, sorry. So what about National Guard? So we have an issue with the National Guard Hospital, Riyadh, in ICU. We have 40 beds, neonatal ICU beds. It's very crowded. It's not the best area that it's very narrow, it's crowded, it's busy. So our infection rate was very high, actually. From 2008, we have 4.7 per 1,000 central line, 4.3. And if you look at the utilization day, the NHSN rate is 0.22. But we are using a lot of central line, and we keep the line for a longer period of time, 0.37. We try to bring it down, the rate of utilization ratio for a central line, but still the CLABSI rate, it's still stays the same. It's higher than international figure. Because NHSN rate is 1.2, and we are more than 3. So how did we approach this disaster of babies with CLABSI that cause mortality, increase length of stay, increase BBD, increase ROP, increase different pathology, the risk of different pathology? Can we move the slide, please? Yeah, so what we did, first of all, we think, as usual in neonatal ICUs or any ICU, the hand hygiene should be improved at all times because it comes from our hands. So we did a very big and hospital-wide hand hygiene campaign that's back in 2009, and then implemented of central line bundle, which just recently was implemented in neonatal ICU in general, because the central line bundle started maybe early 2000 in adult mostly, and then moved to neonatal in 2005 and 2006. So we start implementing the central line bundle. Then we also work how we can promptly remove the central line if not needed, but still after we minimize the use of central line, the rate went down and then went up again. So even our central line utilization ratio was low. So we said, okay, this is the time we have to maybe have a team, CLABSI team in National Guard, just looking at the CLABSI rate, so monitoring the CLABSI central line insertion and monitoring central line maintenance, and 2 nurses always watching the doctor when they are doing the hand hygiene, wearing the gown, wearing the gloves. One of the physicians came to me, Dr. Saif, I changed the gown 4 times. I changed the gloves 3 times. This is waste. I said, no, please, my friend, it's not a waste. The waste, if you have a baby with CLABSI, he may die, he may also stay longer, and he have more chronic lung disease and other illnesses. It was very strict, so this is now we build the culture, because our CLABSI bundle compliance rate was very low, 84% only, and we should be at least more than 95%. So, and again, because the rate is still high, despite we are less using of utilization of central line, more hand hygiene, so we said, let us may have more strict. So we kept our door in neonatal ICU locked, so nobody can go in. The pass to go inside the unit, you have to wash your hands. Otherwise, you cannot wash. You cannot go in. Many consultants got upset, from different specialties, physician, fellows. We said, sorry, this is our policy. Please wash your hands. We are not asking for something difficult. It was not an easy, as Dr. Adam mentioned, changing culture is not easy. So it's well known now in National Guard, in ICU, be careful. You have to wash your hands. You have to wear a mask, etc., etc. So it's a culture. That's it. You have to build it and sustain it. Then in 2013, we start using Curis, which alcohol impregnated cap. This is the green one. So using this one, it makes a lot of difference, in our opinion, because the nurse, before she accesses the central line, she needs to clean it with alcohol for at least 15 seconds and wait for 15 seconds. They don't wait. They just open, give it. and they push the organism inside. And also, we start using this chlorhexidine, 4% chlorhexidine, because what's supplied by the housekeeper, the soap, the built-in soap in the wall, it was shampoo, actually. When I open it and read it, this is a shampoo. It's not something used for a hospital to clean your hand before doing clinical procedures. So, and then we start using the chlorhexidine, which we have a big discussion with the infection control. You know Ziad Mimish? Ziad Mimish is a big figure in Ministry of Health. He was the infection control director. So in their APP, not to use chlorhexidine before 2 months of age. We said, we can't. We have a lot of infections. We have a lot of very sick babies. We need to use the chlorhexidine because it's proven it's better than just alcohol. We are using povidone in the past. So we went, myself and Dr. Hakim, I remember my friend, and we went there, we tried to convince him. We said, okay, because we cannot use the chlorhexidine if it's written in the APP, it's not allowed. So the nurses will never use it. They will listen to the APP, which is the policy and procedure for the hospital. So we said, okay, can you change the statement to say, with caution? When he wrote that with caution, alhamdulillah, we start using the chlorhexidine, aqueous without alcohol for tiny babies, before inserting the central line, before putting the IV, and we can watch. It was very, very useful. This one, sterile one, because that one is not sterile, but this one, the one, the fast, they call fast, is sterile one for central line. Always we use chlorhexidine with alcohol. And this, the 4% chlorhexidine also make a difference. So we saw a difference in the CLABSI rate after using this one. Also, we start to maximize the barrier, so the whole baby will be covered, and strict bundle compliance for that one, strict for bundle. So we did a lot of intervention because we spent almost 4 years. We are not moving. Still, our CLABSI rate is high. So we cannot keep it forever. So we have to do more intervention and more. So we pick line, change dressing. Again, another fight with our colleague. We make the physician, he should do the dressing. Because before the nurse, he will go and change the dressing, but the line will be dislodged. The line will maybe, it's not with a very good sterile, because she will be worried that she will remove the line or the line will be out. So we said, okay, the physician will do it and the nurse will help. طبعا, it was not easy decision for us, but this is what we have to do because we have an issue with the CLABSI rate. Central line insertion procedure stamp before the electronic system. We stamp it, so who insert the line, what time, what's the length, etc., etc. We know what's happening to the central line. So we have a trolley, special trolley, assigned a CLABSI nurse. So the CLABSI nurse, that means every shift, one nurse, if the doctor decided to put a central line, she will stand watching from the washing, gowning, inserting, and any breaching for any infection control, she will stop him. She was empowered. And this is another trick. You have to empower your nurses. If you don't empower them, things will not go straight. So you have to empower them, help them, support them, because they are helping the babies, trying to protect our babies. Physician guideline for central line insertion and standardized guideline for nurses to access the central line. Not any nurse, because in the past, to give a medication, they go to the central line, take the hub in the stopcock and push it. We said, no more. There is a line connected to the pump, at least 1 meter length, put it there, this is for medication. So she doesn't need to go to the central line, she will go in the end of the line for the central line without having an issue. And this will be changed every 24 hours. Because if there is an organism, it will migrate, it will take 24 hours to reach the baby. So we'll move it before it reaches the baby. And then we were very happy. We reached 230 for just 20 days maybe, or for 50 days short from 1 year. We were just trying to reach 1 year with zero CLABSI. But unfortunately we have an incident and then we start again. So in December, and alhamdulillah, in December 15, 2015, we were able to reach 1 year with zero CLABSI. Everyone is happy. Nurses, physician, and Dr. Noura is here, and I take her permission to post her picture. She allowed me, thank you, Noura, for this. She said she was a consultant with us at that time. So we kept going on with the zero CLABSI. We reached 710 days. We were just short from 2 years. We wish that we have 2 years zero CLABSI, but then we said, okay, guys, you did a great job. Thank you. Everybody was happy. We appreciate their work. So doctor is happy, nurses is happy. Everybody is celebrating the events. Everybody, we involve the leaders. And this is a very important. You need to involve the leader to appreciate your staff. So this is Dr. Bandar Al-Ganawi. He came and appreciate our staff for this excellent achievement. This is Dr. Bandar Al-Ganawi. This is his deputy, CMO, Dr. Saad Al-Mihraj, our medical director, and the director of infection control in National Guard, Majid Al-Shamrani. So this is a big difference for our nurses and our staff, physicians. So this is our colleague, Dr. Khawaji, and we are there. This is our chairman, and this infection disease consultant. So we give away mugs with the 710. It was a big event for us. We never think that we will reach 710 days, never. So we said, okay, now we are able to reach, let us reach 1,000 days. So we work hard. Unfortunately, after 710 days, we have 2 CLABSI in 1 week. Imagine. Then we stop, no more CLABSI, alhamdulillah, we reached 838 days. And we were planning to have 1,000 days, but we couldn't. So we celebrated the 500 days, zero CLABSI back in April 2018. Our nurses very happy, our doctors very happy. So everybody is happy. So you see the whole team involved. The whole team work with you to help the patient. This is important to achieve any quality improvement project. You have to involve the team. You have bring their morale up. Talk to them all the time. Show them their achievement to make a difference for continuing and sustaining your quality improvement project. So just to show that we are not doing great in the utilization ratio, it's above the NHSN rate, which 0.22, but still our CLABSI rate is good. So we are not bad in the CLABSI rate despite we are utilizing the central line more. But look at the improvement in the compliance bundle. It's improved. This is what caused the difference. And then we did some statistical analysis about pre and post intervention. Pre the intervention, 15 CLABSI events within 4 years. But after the intervention, only 3 CLABSI events, which give us the rate 0.3 per 1,000 central line days with a statistically significant. And this again, CLABSI event statistically significant, and the CLABSI rate was statistically significant before and after the intervention. So our zero project in National Guard, it's a really big, long journey. So this is what we have a problem. Then we reach 710. Then we have an CLABSI. Then again, 838 days, zero CLABSI. Then we have an infection. We again went up to 820 days. We were planning to celebrate, but unfortunately, COVID came and stopped us from doing anything. But we have an issue during COVID and after. We have a lot of nurses, they left us. Many RT, they left us. We have severe shortage. We got very busy from 2021. Then after, we have some issues with the CLABSI. If you look at the graph here, it's up and down. So in 2021, suddenly we have 6 cases of CLABSI. What's going on? We were shocked. What happened? From 0 CLABSI to 6 cases in few months. So when we looked at the culture positive during our in the hospital. So we looked in May was 5 cases, 1 case of blood culture, but other culture from tube and urine. And then in June was 11 cases, 6 blood culture positive. And then in July, we have again another 6 blood culture positive and 9 from the tube. Different organisms. It's not just one. It's different organisms. We don't know what's going on. Then we, again, as usual, so out of 17 blood culture positive 6 cases, yani 35% of our blood culture positive cases, 6 was CLABSI. Acinetobacter, Staph epidermis, Pseudomonas, Enterococcus faecalis, and Staph aureus. So it's not outbreak actually. So we think what's going on. So we have a meeting, multidisciplinary task force with the infection control. We said we need help. We need to go and see what's going on. So we look at the root cause analysis. What could be the issue? Where is the problem? We met with the infection control. They wrote their recommendation. We distributed to the healthcare provider. We talk to each other. We are meeting every week about what's the progress of our infection, and we change the practice. So then we look at the, as usually as inequality, fishbone analysis, practice, hand hygiene was breached. We are not using the appropriate disinfectant. As we said, they are using shampoo in the unit, so we said no more, use 4% chlorhexidine to improve the cleaning. And the supply, you know, during the COVID, there is a lot of problem with the shortage of supply, shortage of cleaners, shortage of this. And also in the same time, the administration, they are telling us, okay, we will move next year to new hospital. We will move, so we cannot buy new equipment, we cannot buy too many things just to improve our the environment and quality. And then also we look at the staff. They are washing their hands, they are using alcohol rub, but within not at the optimal time, which 20 seconds at least. Also shortage of CRNs, which clinical resource nurses, shortage of nurses, shortage of respiratory therapists. And the respiratory therapist was not part of our huddle before this event. So we including them, we are asking them to be with us to hear about the infection happening in the unit. Then we look at the environment. You know, our unit was very old. Try to improve. We are moving, so we are waiting for the movement. We did not do a terminal cleaning for many days, many years, actually since 2020. So then we found something else. We found the sink. The aerator was very dirty. It's really ugly. If you look at this one, very ugly. And this is the whole, when I saw one, I went to the whole, all the sinks in the unit. This is the faucet, all of them like this. So I thought maybe when we are washing our hands, it touches this area and taking the infection with us. This is why it's different organism. So we did the culture for this aerator and we found the same organism that we are facing in the unit. So we asked to change the faucet and the aerator in a monthly basis. I mean, the faucet will be a new one, but the aerator, this one, we need to change it every month. Even we tried to find it in the medical market, we couldn't. We found it in Sacco. We bought all what Sacco have, maybe 200 ones. They said, get it us. We'll have it every month to change it. We have almost 20 sinks, so every month we change it to make sure it's clean. So what happened? So this is when we did the root cause analysis, knowledge deficit, we are retraining and re-education, breaching the hand hygiene. We have strict monitoring for hand hygiene, and one refused to do hand hygiene will be reported to the quality. So SRS will be raised, it goes to quality, quality goes to infection control go to medical director will come to us and ask what's going on. Why this medical or nurses did not wash their hands, what's their objection? And so assign 2 nurses to audit during procedures and increase number of new nurses in the unit, so we need to make more extensive education for our nurses, more teaching, more practicing for hand hygiene. Crowded in the unit was small, as we said. We say, okay, not everyone will be joining the rounds. Maybe some of the people that are not needed. We don't need 3 RTs, we don't need 3 pharmacists, we don't need even medical students. We just take them away a little bit from neonatal ICU. Inappropriate cleaning and disinfection of the equipment. The BCT, the patient care technician, were cleaning the equipment, and the housekeeper was cleaning, but they are not doing it the right way. So we start to audit them. And shortage of clinical educator. We train the senior nurses to be a clinical educator, and also high turnover respiratory therapists. Many respiratory moved, and now we have to train again the respiratory therapist. So we're changing the aerator every month, and you look what happened. The infection rate went down significantly from here maybe 21, 11 to again 6, 9, 6 to, and more than this, 0 CLABSI. From 6 CLABSI 4 months earlier to 0 CLABSI 4 months later with this extensive intervention. So you need to work hard and extensively to protect your babies. Then, alhamdulillah, in September 28, we moved to the new hospital. It's a really nice hospital called Women's Health Hospital. And it's a very nice, this is our physician, everybody's happy, our fellows behind the screen, you can see them. And this is a 60-bed neonatal ICU, and 34 step-down beds, which 96 total. We serve 22 weeks or above, very high-risk patient. We have a lot of high-risk patients coming from everywhere in the kingdom. We have almost 9,000 delivery per year and more than 1,000 admission after we moved to the new hospital, because it's a new hospital and people, they start to know about it. So it's different. So last year when we moved in 2024, we have more than 1,000 babies admitted to us. This is the new ICU. This is the entrance. The family will wash their hands, wear the gloves, wear the mask and the gown, and we always promote breastfeeding. Breastfeeding, it makes a difference. Even you don't have enough milk, you just put a milk in the cheek of those babies, it improves their immunity. And we see a big difference, subhanAllah, for feeding intolerance, for infection rate less, length of stay less, by just promoting breastfeeding. So when the mother comes, she will read this one encouraged in addition to our encouragement. So this is the unit, clean unit. Big distance between the bed. It was before maybe 1 meter distant. It's just adjacent to it, but now at least 2.5 meters. 5 minutes. Then with this nice clean unit, which designed based on our need, unfortunately we found a mistake, which having the sink inside by the bedside. And the sink is not at the standards, it's very shallow. So we said, close this sink, don't use it. But when we didn't discover till we have the problem of the infection. So this is our rounds, spacious. We have the fellows, the consultant fellows, RT, pharmacist, dietitian. And this is our team also. We are happy. This is our fellow, putting the insertion central line. 2 nurses to hook the TB in. And also when they change the TB in daily basis, we should wear all the BPU, make sure that you use sterile gloves, sterile gown, not sterile gown, and also sterile drape to make sure nothing touching the baby, so it will done under sterile technique. So what happened? Only 1 month after arriving to this new hospital, we have 6 cases of collapse of baby with Klebsiella. Not Klebsiella, sorry, Pseudomonas aeruginosa. Pseudomonas aeruginosa. 2 from the AT tube, 1 from the eye, and 3 cases from the blood. And unfortunately, we lost 1 baby. 1 baby died due to the Pseudomonas infection. So we said, oh my God, what's going on? So we think maybe the sink that's making the problem, so we stopped using the sink. And this is 2 cases eclampsia before we move, and 1 case when we move to women's hospital. And we did the fishbone analysis. It's less because we have a new hospital. Everything is done in a very well way. So practice breaching hand hygiene, inappropriate use of disinfection that I show you. And then supplies, hand wash was not appropriate, so we added more. And also the doctors and nurses, they are not using hand hygiene more, and we have shortage of staff. And mostly environmental, when we found the sink is shallow and splashed the water around the baby on the beds. So the multidisciplinary and root cause analysis came up with that the sink may be causing the issue. So we stop using the sink and add Avogard. Avogard is a chlorhexidine with alcohol. It can be used for even before the procedure. We learn it from the OR when we go to L&D and we rushing to see the baby inside. They are using the Avogard and go for cesarean section. So we said, okay, because we cannot use the sink, we need to use something maybe equivalent to hand hygiene. So this is the Avogard. We put it everywhere before entering the room and in the bedside almost. And this is what they are using in the cleaning from housekeeper. So we added the chlorhexidine here to make sure that it's really disinfectant. And the shallow sink, this is outside unit, we added a bigger sink with the deep so the doctor can do the hand hygiene and can do their scrubbing before the incident. So what we found, this is our rate of bloodstream infection from 21 to 24, and you look at the rate for all base I, 1.2, 1.2, 2%, and then 0.8 when we moved to women's hospital. So there is a significant drop in the rate of BSI, mainly in 2024 when we overcome the problem. And the eclampsia rate, it was 6 in 2021, 22.3, 23.3, and 2 in 24, and make us our eclampsia rate over the last 4 years is 0.7 per thousand central line. In 2024, it was 0.4. So our rate is acceptable. We are striving for 0, but still we need to improve better. So as of the first quarter of 2025, we have 2 cases of BSI, Enterobacter homanchi and Enterobacter kewaki, and the rate 0 CLABSI in the first quarter. But I will tell you, from the last CLABSI, we have 530 days. From the last CLABSI we have back in April. So this is our journey. We have a bad incidence of CLABSIs here back in the 2013-14, and then we improved, till we reach this stage now, and we are doing better. And the same picture we show from Dr. Adnan. Always you see the tip of iceberg. So multidisciplinary takeaway message: multidisciplinary involvement is important. Consistent reminder, re-education, training is essential, and auditing. This is what is my experience here: auditing and monitoring, surveillance for all BSI, all infections. Every week we sit together as a team and discuss many issues. One of the issues, the standing issue, is infection. So how many babies we have culture positive? Regardless, blood, eye, wound, respiratory, what's the culture positive? So we are monitoring every week because it makes a difference to manage your patient. If the patient got sick, you know what organism you are dealing with and what the sensitivity, and also monitoring CLABSI, which make a difference in the rate of CLABSI. And small changes make a huge difference. So what you see, the success, but what you don't see, the failure, the disappointment, the sacrifice, the persistent, continuous sustaining of monitoring, disappointment, hard work, and dedication, more discipline. So again, to improve your quality of patient care in your unit, you need to involve all your team in your quality improvement project, sustain it, monitor it, show your team their result, because what they do, it's their work, it's not yours. You are the leader, but what they do, it's there. So they will be happy to see their outcome. And I will stop. I thought I have time to talk about prevention of CLABSI from the literature, but I will stop at this time because not to exceed the time limit. Thank you very much.
Thanks, Dr. Saif. Always give us powerful insights on how structured teamwork can result in measurable safety outcomes as usual. Next, we'll have Dr. Abdul Hakim Gattan. He didn't want us to say a lot about him, but to me, he's the legendary Dr. Abdul Hakim Gattan. He's a leader and a neonatologist at King Faisal Specialist Hospital. He's been involved in many national improvement neonatal care services. Today, he's going to talk to us about quality improvement in respiratory care to complete building our safety culture in the NICU. تفضل دكتور عبد الحكيم.
السلام عليكم وصباح الخير. It's nice to be here with you this year, and I think the society also would like to apologize for the last 2 years that we couldn't, do the annual meeting here in Riyadh. I'm sure some of you miss it. My presentation today is about the quality again, and you will hear about quality for the next, for the whole era you will work in the NICU, but quality is important. And I will talk about the respiratory care issues, about in the quality in the respiratory care of a newborn. I think the quality is coming with us in all aspects of our life. We need quality education, we need quality food, quality sleep, quality everything. We wish to have in this city also quality traffic, though it's very bad. So hopefully we can present it soon. But as we're saying, the quality will be part of our life. Actually, we are, every day looking for a better quality housing, living, and so on. So I think no exemption, and no doubt that medical field need really to concentrate on the quality. And the quality of our work is saving life, decreasing morbidities, lower down the mortalities, and actually, it's involved all type of medical practices. So here we are, I think it's the move from everywhere. I think at all levels and at the administrative level, that quality should be part of the, our curriculum and one of the early items in our agenda. I don't know if they are teaching, quality in the medical school, but I think, it should be also. That, we don't only diagnose and treat, but during treatment, we look for opportunities to improve the type of our, intervention, the arrangement, the devices that we use. And I think this is, forever, it should be, our talented to do that for, a better, service and more, efficient way of doing the system. Nonetheless, we are seeing this quality improvement for the last few decades. Since I started the fellowship in neonatology, now it's about 3 decades or more. There was a lot of steps, and those steps are you may see that, or you are living the benefit of those steps. But at one stage there was, as you remember, I'm sure you are aware, how much, the drop in the neonatal mortality, how much, we are saving babies with a good quality of life, including those tiny babies, the movement of the, viability age, from down when we were in the medical school, they were telling us anything below 28 weeks is non-survival, and you should not look after them. And now we are moving down to 24, to 23, and people also talking about 22. And so I think it's something that we should, beside knowing that it is happening, is to embrace on it. Teach our new students, new doctors, we should teach them that they should look for the quality in their work, not only just to do the work. So we'll try to go over some the identification, evidence, and bundle approaches and implementation. This is a general type of things. So as introduction, as I said, providing appropriate, this is in particular about the respiratory care. To provide the appropriate respiratory care of neonate is very essential to minimize complication, and the intervention decrease the risk of the lung and the brain injury, and particularly in premature infants, and reduce the mortality. The interaction between the intervention in respiratory issues and outcome and long-term benefit for those patients and their IQ, their developmental stages later on is well known and well studied. So reducing the neonatal mortality and improving the quality of the life for the survival. Now this is some of the old slides that I have. For a long time I didn't see those type of X-rays with the severe pneumothoraces or tension pneumothorax. And for our new colleague, you may not saw this for a long time, but that was sort of daily happening in our units before when we were in training. First thing they teach us when we go to the NICU is how to drain pneumothorax, okay? Because draining pneumothorax was a major issue. So this system on the left side is how to drain, simple. But it was hanged beside every baby bed, because we know while they are in ventilator, they may pop their lung at any second. And then that, usually take maybe a few minutes to cause them severe hypoxia, and if not treated, it may cause them even death. So this was a very important way to drain the pneumothorax immediately, even before X-ray and, before you do a lot of investigation. Even if they pass through the pneumothorax stage, then they will go to this stage, the stage of chronicity. And, to see this bad lung, destroyed lung, no wonders, because the way we were ventilating them, the amount of oxygen exposure, the amount of, all the offenders that happen to the lungs, end by severe lung damage, and a patient who doesn't want to improve, and you may lose some patient, and we lost a lot of patients in the past because of that, especially those very low birth weight that exposed to a lot of ventilation. That was our tools 3 or 4 decades back. This is called secrets. Simple, 3 knobs, pressure, can give a lot of pressure, can cause a lot of pneumothoraces. So you need to survive with it at that time. Beside it is the incubator. And you can see simple incubator cannot maintain the temperature many times, cannot maintain humidity. And then at the end, you will have a baby who's getting dry, acidotic, and then you try to ventilate him to compensate. And of course, during this procedure, you destroy his lung. And then you end by severe lung disease. And now this is the progress. This is the quality care now. We have 8,000, baby log ventilator that can, with the simple, touch of the knob, you change it from one mode of ventilation to another, to high frequency, to very gentle tidal volume, targeted, and so on, and to the more advanced incubators that more efficient and save a lot of lives. So the quality of our equipment is very important, and I think this is, you can, should recognize it as times go by. So it's an imperative and embarrassing that the continuous quality improvement in the NICU from 1960s to 2020, there is major advances that happen. Beside, the administrative issues, and beside the surfactant replacement, the new modalities of the ventilation and the support, all these lead to significant improvement and reduction in the mortality and the morbidities of those tiny babies. So it's a complex issue. About respiratory, it's a complex. You can see that there is, now a lot of different ideas how to save the lung, from non-invasive, from LISA, from mist, from, of course, different or early CPAP management, avoiding positive pressure ventilation in the delivery room and so on. So this is, this to define the problem is very important. So it's not only the ventilatory setting, it's the infection, it's the airway obstruction, the lung development, and it's multifactorial issues that, your goal should be knowing all these factors to implement non-invasive strategies that reduce mechanical ventilation exposure through standardized evidence-based protocols. So this is, in short, what we want to do in the current and in the future, and to improve our ways of looking for how to deal with those patients. So there is increase now, as you are aware, that there is increased trends to improve, the non-invasive ventilation modes, from straight CPAP to non-invasive ventilation and synchronized one to high-frequency nasal ventilation, and many different things. So these different ventilation modes need to be studied well, and there is a lot of study going on around it. And to choose the best, depend on how good you are in doing it and how you're going to target it. And I think this is what we will talk about in the way of how to apply some respiratory changes in your team, in your unit, to make things, to make things better, and to, upgrade your unit to be more of quality care rather than just, to make them survivors. So I mean, the key ingredient for success in these issues will be to have, everyone to be involved, to have willingness from the unit, and their ideas should be, based on some previous studies from, published articles. What is going on? Can we do this? Can we apply it to improve our patient care and to delivery, and to be consistent and to improve the quality? So at the end also you need to report such type of work. So in the quality improvement framework, as you aware about it, it should be the aim. What is your statement? You should state your aim very clearly. So what you want to improve and how you want to improve it. The degree of improvement also important. I want to reduce my patient rate of pneumothoraces from 3-4 times per year to 0. Let's go to 0 pneumothorax rather than only than the driver diagram. There should be some schematic way of doing things, and then you go through one of those known cycles for quality improvement. BDSA cycle is one way, and this is the BDSA cycle, where you have the plan, do, study, and act. And I think it's simple, and it's made simple to make life easier. So for plan, you need to define exactly the problem, and then how you carry it in the do, and then how to study it, what type of data we will collect, and based on this data, we will act. And this act will mean maybe some protocols, some guidelines in your unit where you can make things better. طيب, is this studied, the multi-type of intervention? It is, yes, and it will improve the overall outcome. So in pediatrics 2016, there was this publication of 100,000 babies. They were all small, very low birth weight, that the program to be implemented, multifaceted quality improvement program, where you can incorporate in their management to improve their outcome. And I think this is important. In the respiratory aspect, which is very important, as you know, we maintain them alive many times. طب بعد قدر الله إننا we respirate, we ventilate them, we support them. And how much of support we are giving? Are we giving harm with it? So all these things should be, put in mind. And so this is suggested respiratory care bundle that I think most of you, if not applying all, but applying most of it. But to apply it as a one bundle, I think it will make also more pronounced outcome benefit. So to defer the cord clamping, and this is well studied and well known now, to early nasal CPAP rather than to intubate and ventilate. And we are talking about very low birth weight babies, less invasive surfactant, and early caffeine and standard care. We'll go over these issues by one. So how to measure the plan, how to the measurement, the process. So this deferred cord clamping, the percentage of eligible birth receiving 30 to 60 seconds of delayed cord clamping, how many of them, early CPAP, and the percentage initiated on the proper setup, and the less invasive surfactant usage, how many times we use LISA or mist, and caffeine protocol. Then you apply your, for example, BDSA example for the deferred cord clamping. So you will plan it, you will do it, and while you are doing it, you need to know also that there should be involvement of obstetrician, and many times I'm sure your obstetrician will be the one who cut the cord immediately without thinking of timing and so on. So you need to discuss it with them and to try to apply it with them, even in the phase of planning of the intervention, to do and to study the outcome and then to act and to make it as a protocol for your unit. For example, the early CPAP in the delivery room, to do indication usually of the CPAP, to put a clear indication when to apply CPAP, and it should be started, for example, to babies who are spontaneously breathing, even if they are tiny. Now, even the extreme low birth weight, we go for nasal CPAP without using intubation and giving them a chance if they are doing the effort. So, what type of sitting, the target SATs, and starting FiO2, and the equipment setup. You need to have a good and reliable equipment in the delivery room, and tested well before even the delivery. What else? In the process, you need a multidisciplinary team governance. To have people to agree on something need a lot of effort. And I think from the previous lecture with Dr. Saif, we learned that to do a change, you need to do a lot of discussion, a lot of communication, a lot of communication between the team itself, how to reach a better way. So the core team, neonatologists, the nurses, respiratory therapists, obstetric, anesthesia. Also, we have support team. In case if we have drugs, you need to be given the infection control, in the hospital, and so on. Even the biomedical engineering for the equipment. This equipment sometimes get, not working proper. So you need somebody who are efficient and will fix it on the proper timing. And the leadership. The leadership, of course, will help, to sit all this together and make things happening. For example, for the aim, how to sit at the aim, for example, for a patient, delivery room management, to reduce the mechanical exposure, mechanical ventilation exposure, to avoid intubation. So you can put an aim that within 3 months or 4 months, we will reduce the intubation of extreme low birth weight by 30%. And how to measure this, how to have the safety requirement to have it, and so on. So you set your aim during the planning, so it will make it much better and much easier to reach your goals, which should be defined before you start. So the outcome, mechanical ventilation exposure for bronchopulmonary dysplasia. What is the outcome that you will measure from this intervention? You will measure the exposure to mechanical ventilation, bronchopulmonary dysplasia, home oxygen at discharge, or length of the stay of those babies. All these things need to be looked at. Then you can discuss how to reduce the rate to, for example, of pneumothorax to less than 2%, the severity of IVH to less than 15%. And of course, you need to keep in consideration what is your baseline results, what is your baseline data. If you have high rate, for example, of IVH grade 3 and 4, let's assume 25% in extreme low birth weight. If you reduce it by 10% within the allocated time, that's a very good achievement. So you need to have a reasonable goal and to go for it, to reduce NIC, to reduce all the complications. I'll give you some example of the intervention that we did at King Faisal in our unit. We are smaller than National Guard unit. We have only 30 beds, but we try to utilize the mist as a way to give non-invasive way to give surfactant, so to reduce the exposure to mechanical ventilation for those tiny babies. So all those babies, they were very low birth weight, and we managed initially we start to use the mist in the 2018, 2019, but not in consistent way. It was like, sporadic cases that we use it, and it was deferred to the preference of the consultant, the one who's covering, to give, mist or just to go for insure. We were doing insure before that. So then, we decided to make it more practice. So there was some training for our senior, neonatology team, the assistant, the fellows. There was a training to do it, and we start to do it more frequent by 2021, where we have a lot of patients that have been, we give the mist through the, we give surfactant through the mist procedure. And you can see here in number of patients received surfactant via the ET tube was 61 in 2020, but in 2021 it was 42, so it's less. But the number of people, or of the very low birth weight that receive surfactant via mist on the second year, which is 2021, it was 48, compared to only 2 receive it through the insure technique. So there is clear increase of number of patients receive surfactant through mist procedure. Doing the surfactant through mist, there is some patient that they don't tolerate it. And the number getting less, we treat them, we pre-treat them with some atropine, small dose, actually half dose. We treat with atropine to avoid the bradycardia, and we treat them also with some sedation. Initially it was full 1 microgram of fentanyl per kg for tiny baby. Then we decide to lower down the dose to a smaller dose to avoid weakness of their respiratory effort. But overall, things improving. And so the instrumentation, which is, the special, catheter to put the surfactant in the trachea, is not available in our unit. So we are using, just the angiocath. And I think I have, So this is the angiocath we use. And because there is no numbering over this angiocath, we decide to put a small, tape or sterile strip over the sides, how far we should put the tube inside the trachea. And that was done usually by the using we were using the laryngoscope, and some of our colleagues, they like to use the video laryngoscope that they can do it under the video procedure. Then of course it is done while we are using the non-invasive ventilation or CPAP, and usually it's with RAM cannula. And the mist was delivered mostly in the NICU, though there was some few incident that the doctor decided to do it inside the delivery room, and it went smooth and there was no problem with that. This is the recommended, on the right side of the slide, this is the recommended, catheter, which is made for this purpose, but we use just the usual angiocath till we buy the new catheter. So, non-invasive delivery of surfactant is one way to go, and there is some information, there is some studies that showed improvement in the outcome, and I think it may, become a regular process in our units. So this is a report recently published in the British Medical Journal, I think. And though the number of babies is not that much, there was 32 in the invasive one versus 57 in the insure type of delivery of surfactant. It's from one unit in China, and this is their representation of their data, where they have the duration of mechanical ventilation not much differ. and the duration of oxygen therapy also not that much differ. But when you look for the rate of bronchopulmonary dysplasia, though the number is small, and they admit that, but there was some reduction from 36% to 31%. And this, on the bigger scale studies, it may show a better result and improvement. Another study also, but this is not in delivering surfactant, but in a different mode of ventilation of those babies. This is also a recent one, published this year, I think July. And basically they are this is a multi-center study from China, involved 342, all of them extreme low birth weight. So it's really a big study, talking 24 to 28 weeker. And you can see their analysis of different item of care showed a preference of the high frequency. Initial high frequency nasal high frequency ventilation for premature, extreme low birth weight. So for both, there is no treatment failure, more towards the better outcome in the high frequency group. And so the conclusion of that study was saying it seemed to be superior than continuous positive nasal pressure, and it will reduce the need for intubation. And maybe we'll see more towards that way of intervention. In our unit, we use high frequency nasal ventilation, but we use it on selected cases where we have difficulty to maintain them with regular CPAP or non-invasive ventilation through nasal cannula. So I think, again, back to this study, you see there is a lot of intervention that we do after delivery, at the time of delivery, in the delivery room, in our NICUs, that affect the outcome, respiratory outcome. So all these issues should be kept in mind, and we should work to improve the service that we're giving for those babies. And of course there will be more studies needed in the area of lung recruitment and monitoring and the technique of the administration of surfactant, and also in the synchronization. And all of these, though it can appear to you small or partial effect, but if we add it together, I will finish soon. If we add it together, I think it will make a difference. So the multifaceted type of quality improvement in our care should be considered, and we should aim for it in all our unit. Thank you.
Thanks for all the speakers, for the insights on all kind of quality and safety in the NICU. Would you please come to the platform to receive questions, please?
Thanks for the speakers. And I will make one question for all of you. I don't know which one will hold it. When you talk about quality of life, sometimes when you have problems catching the quality, you need a very transparency in the reporting it. For example, medication error, occurrence of collapse. What is that transparency or شفافية في reporting such problems to improve our quality? Abdul Hakim, BBD and Lisa, BBD and non-invasive, it doesn't show that much dramatic reduction in the bronchopulmonary dysplasia with all this intervention. In your study, although the number is very low, very good reduction, almost 50%, صح? So how you can compare your global conclusion that there is no really reduction and between your study that we have 50% reduction in BBD?
In our work with the mist, It have been, collected and we drafted as a presentation, but it's not published yet. Our rate in our unit for bronchopulmonary dysplasia for very low birth weight is a low one. We are talking about low 20%, 22, 23%. So we are not seeing a lot of chronic lung disease. Can this, intervention of minimally intervention used by surfactant through mist, can it reduce the bronchopulmonary dysplasia farther down? I think this is what we should report to you in the next year or the next 2-3 years. We will collect all these data and we'll let you know. But definitely I think it helped. Why? Because most of the time when we use the insure technique, the tube stay there for 12 hours to 24 hours, sometimes 2-3 days, because people, they will be afraid to remove the tube. So, but when you use this technique, we see a lot of babies within 12 hours, their oxygen requirement went down, they didn't need intubation, or avoid intubation from the beginning, and I think they do better. So over accumulative data hopefully will show better outcome.
شكرا جزيلا بروف. الصراحة هي المشكلة في reporting in general in the hospitals, the way how you use it and the way how they investigate the problem. So right now we are hearing the people, if he get upset from any other person, he said write OVR against him. He's looking to it in a way that it's like a punishment. He's trying rather than to fix the problem or the error or the mistake, to find the best solution to avoid it in the future. He's trying to personalize the problem that he's complaining against X person. And honestly, to the degree that we report one case before, we wrote OVR because one of the operations is cancelled. It's major, we intubate the baby, we prepare everything, it was neurosurgery. And I asked them to write OVR just in the future because there is a lot of operation after we intubate the baby, prepare everything, and they cancelled all of a sudden. The consultant himself came shouting to the NICU, why you are writing OVR? What we did? You should ask us before we write OVR. I told, sorry, we intubate the baby, we told the parents, we prepare everything, we are about to shift the patient to the OR, but it's our right and the patient right and the family right to avoid such a problem to happen in the future. Even though he's not convinced, because again, on the other hand, or in the other way, the people, they will look at it, the way they will investigate, they will call the doctor, they will investigate as if he did crime issue. It might end by punishment of the doctors or nurses or whatsoever. And I still remember one of the nurses, I'm sorry to say that, she gave them the medication twice. It was hepatitis B. And she is the one who reported herself. So I called, I was acting head at that time. So I asked the people if it's possible to thank her, to give her something that's to appreciate that she's reporting even herself. But we end by the nursing office. They gave her final warning letter and threatening that she might lose her career or it's under supervision for 6 months. And next day she came with the other nurses. They came to me crying because you told us, you encouraged us to write, to report, even to the degree we report ourselves. And next time we will never report any case. And honestly, I tried my best. After a lot of communication here and there, we removed the warning letter. So it's both how we are looking ourselves to the problem and the other people how they are looking to fix, rather than to fix the problem, how to punish the people. Thank you very much.
Assalamu alaikum. Many thanks to all speakers for their inspiring talk. My question is to Dr. Saif, because I believe that we have to take what you have done and achieve seriously in each step. One of your slide, you have mentioned you are doing weekly dressing by physician. And by CDC recommendation, it's not indicated unless something, so you have to do the dressing. but we have to respect your data and the outcome. So do you do weekly dressing even if it is not indicated?
Thank you for the question. Yeah, you are absolutely right. I have the same question from our colleague, but we have an issue with CLABSI many years ago. I agree with you. All the CDC, all the recommendation, even INIC, which International Nosocomial Infection Control Consortium, they are saying you don't change the central line unless it's soaked, wet, or dirty. And we are using central line cover with the transparent dressing so we can see it. The worrisome from neonatal ICU changing the dressing every week from abrasing the skin. The skin maybe is sloughed or something. But we are trying to go with the policy because if we leave it till it becomes dirty, wet, or soaked, maybe will be missed by our healthcare providers. So we just continue with the policy. We did not change it yet, but we are thinking to change it and watch. But we are afraid. We don't see CLABSI. But I totally agree with you. It's not a recommendation from the CDC or even from an INIC recommendation. Even the European, the Manzano, he published a paper just 2 months ago reviewing prevention of CLABSI. Mention it clearly, not to be changed. For adults, maybe it's different because they have a thick skin. They will not be scaled or become irritated by changing the dressing on a weekly basis. Thank you.
Any more questions?
Just simple comment for that. The beauty of quality improvement projects, that's, as we say in Arabic, أهل مكة أدرى بشعابها. That's even you have two hospitals in the same place, that doesn't mean they will follow exact things totally. So if I believe these interventions might improve our cases, I should follow, even there's no strong recommendation for that. It's totally different from research. And the other issue, you have a lot of quality improvement projects, they are not following exact bundles. So there's two publications in pediatrics. One following, still using indomethacin for IVH, and they put it part of their bundle. And the other one did not follow. And both of them reached great. That doesn't mean what they put there, I should follow 100%. And this one may be weak evidence, but I can apply it because I believe in my situation is different from Canada and USA or whatsoever. So it's not copy-paste from the others. Thank you very much.
Take advantage of being here. One thing that fits all, لما الدكتور عدنان قال لا يتبع من لا يطاع، لا يطاع من لا ايش حضرتك قلت؟ لا رأي لمن لا يطاع. فهو الفكرة من فين نجيب اللي يطاع اللي حيأمر كل هذا كله؟ من أين يؤكل الكتف؟ والله يعني we all know this. We have to have power. إحنا we're consultant. I know we have power sometimes, but it's not اللي يطاع. I want you all, we don't have time, I want you all to reflect on this. يعني what's the best strategy to maintain gain over time? يعني you all had gain, ما شاء الله تبارك الله, in your projects, but how to maintain gain over time?
Well, I think if you allow me just to comment, first of all, you involve your team in your management, in your quality improvement project. Second of all, have a frequent meeting, show them your outcome. This is your work. This is what you have done. Thank you very much. We appreciate. Third, involve the high authority. If you involve the medical director, even the CEO, it makes a big difference in the team. They will listen. They will say, oh, this is a big issue, so we have to keep it and maintain it. And this is the way, this is what I follow the strategy, and it works very well, mashallah.
طبعا الاشيو هنا انه do you need to be a head of unit to do these changes? I think if we feel responsibility, all of us at the level of We know what is the limit. Let us concentrate on the patient and the outcome of our patient as a unit, as a worker in this unit. From the nurse to the doctor to the respiratory therapist, if we concentrate on the patient outcome and that we are here to do this job, to do it, I think it will be easier to find somebody who to lead us. But if somebody, wants just to go with his own mind and do whatever he wants to do, will be difficult to control. Even if you have a good head section. He will resign next week.
One last question here.
Okay, shall I answer or? Just a simple comment. There's different levels and argument how to convince the people. Administration, you can convince them by saving money, mainly. And your colleague by looking at the data. Nurses mainly will be convinced if they see the result of the patient care. And to have a project like IHI saving 100,000 death. In 2006, they convinced more than 320 hospitals across the USA to save the life of 100,000 babies. How they did it, there is a special approach. They call it Cotter way. And the way how to approach the people, it's a systematic approach, not only single intervention or whatsoever. But at the end, really, you are right. I'm always saying or telling my colleagues that's really practicing quality. It's need sabr ayub, حقيقة, to be able to continue to convince the people. As Prof. Saif mentioned that they stay for how many years now? So not to start by 2 to 3 months, it's, I fed up, I tried my best, and you should try for years, not for a few months.
For the sake of time, we have one more question here, last question.
Okay, for Dr. Saif, congratulations for your excellent achievement in the CLAPS project in your unit. Do you have chlorhexidine 1% without alcohol or 0.5% without alcohol in your unit? And if not, do we safely can use chlorhexidine 2% for the extreme preterm baby less than 28 weeker? Thank you.
Thank you for the question. The recommendation not to be used. However, we don't have 1% or 0.5% chlorhexidine stick swab, so we are using it. And we ask the nurse to keep it for a few minutes and wipe it with normal saline, so not to do some irritation to the skin. We are using it for more than 15 years and we are doing great in this matter. We have no issue. But I agree with you, more than 10% or with alcohol should be used more than 4 weeks of age or more than 1 kilogram of weight. Thank you.
Thank you very much for our distinguished speaker and your attention and engagement. We will finish our session, first session. We'll take a break, coffee break for 10 minutes. We'll be back here at 35 or 40 maximum.
Thank you very much, all. We might extend it a little bit, 15 minutes, but inshallah we're on track today. Thank you very much.